NEI Spring Congress attracts the world's best faculty to teach clinicians like you psychopharmacology essentials according to adult learning principles. Register today to join leading experts at our 8th annual event, being held May 8th through the 10th in person in Philadelphia, where I was born and raised, and via simulcast online. Use discount code NEIPOD25, that's NEIPOD25, to save $100 on your registration at nei.global/SP Congress 25F. That is nei.global/SP Congress 25F. Discount good on new registrations only.
Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast, and today we have a very important topic and a good friend and real expert in this area, Yu Moutier. Christine, how are you?
Doing so well, Andy. Thanks so much for having me on, and hope everyone is doing well and hanging in there.
Yeah, well said. Okay, so what we're talking about today, of course, is the warning, the bolded box warning for antidepressants, specifically with respect to suicidality in children, adolescents, and young adults. And maybe we can start, Christine, with just a little background. What was the background and the rationale behind the FDA's decision to do this?
Yeah, so the original black box warning, we all know, was back in 2004. It was based on a large set of clinical trials data the FDA had collected up that looked originally concerning with some case reports. There was a lot of media hype that occurred, and there were families who had lost children and loved ones. And when that loss occurs, we oftentimes, I think, mistakenly will identify the proximal factors and not understand the complexity of suicide risk. So all of that alongside the 4% rate of suicidal ideation and behavior versus the 2% in placebo. So that additional risk that looked like it was there, again, mostly for suicidal ideation, some suicidal behavior, no suicide deaths, was enough alongside those other factors I mentioned to convince the FDA to make that decision back in 2004 when it was, I will add, very controversial at the time. And actually, in full disclosure, the organization I work for, although I didn't at the time, I was a volunteer though for AFSP back then, but AFSP was one of several organizations that testified at that FDA hearing, warning about the potential negative unintended consequences of such a black box warning. And I'll just add one really important piece to this, which is that in those studies, there was the opportunity to measure adverse events. There was not the opportunity to measure improvements in suicidal ideation or previous suicidal behavior. And that's a really significant missing piece in what the FDA was looking at back then.
Boy, it sure is. I wasn't aware of that. And many people listening may not be aware that it was only a 2% difference, which is important, of course. And again, you're mentioning that it was suicidal ideation and behavior, but not completed suicides. So what was the initial goal for this? What was the idea behind this? And then how has it impacted the prescribing practices for children and adolescents?
Well, I think the intention truly was to have a best case scenario where pediatricians and mental health professionals, as well as parents, would have a greater awareness of the need for close monitoring of all of it, of any changes that can occur, especially at the start of treatment in those early days and weeks. And particularly, the warning was for young adults and children, although then was later modified to, and the data showed really was only for 18 and under. And so that was the effect, the intended intention on for the black box warning. I think the challenge is that black box warnings are usually reserved for a very dire sort of next to last phase step before a medication can be pulled altogether due to things like liver toxicity and other physical types of toxicities. And so this was, my opinion is that it was a misapplication with a good intention of increasing the monitoring that unfortunately had many unintended consequences.
Right, and maybe we could talk about some of those unintended consequences. And before we do, Christine, you mentioned originally it was 18 and under, but the actual warning was expanded, I believe, to young adults defined as 24 and under.
That's right, even though the data that was analyzed actually showed the reverse to be the case, that the actual additional conferred risk was for only age 18 and under. I'll add one more piece to this, which is that 3 years later, the FDA decided to try to have some additional impact by modifying the warning. And what they did in 2007 was to add a significant statement as a reminder that major depressive disorder itself confers a high degree, probably one of the most potent risk factors for suicide that scientific studies shows. And so they additionally tried to make that step, I think perhaps as a way to try to mitigate some of the things that already were coming forward by that time.
Yeah. And so what have been some of the unintended consequences? What has happened since then?
Well, what the data shows, and there's a number of studies, the Mental Health Research Network follows literally millions of patients. And so some of this data is from these very large data sets that are reflective of real life practice that's going on around different parts of the United States. And so one of the most concerning things was that immediately the rates of diagnosing depression in both young patients, pediatric patients, but also young adults, also middle-aged and older adults, the rate of diagnosing depression dropped down. And those rates, again, per age group, really across the board, went from what had looked like a very beautiful increase in the recognition of depression as a potentially treatable and serious medical illness, even in primary care, to that rate of diagnosing and treating dropping downward, again, across all age groups. So there was sort of a bleed over effect into the care of older patients as well.
I was not aware of that, Christine. I knew in younger patients that happened.
Yes. And so it was less identifying depression and then less lower rates of treating depression as well. And even amongst those younger patients who were diagnosed with depression, the rate of not being given treatment among those who even were receiving a diagnosis also went up. So there's sort of a double whammy of, I think, clinicians pulling back in a state of hesitancy or fear to even make the diagnoses that they were becoming more comfortable with making in the years prior. And then even when diagnoses were made of depression and other mental health conditions, but let's just say keeping it just with major depression alone, the rate of treatment, both using medications as well as other forms of treatment. So that was even analyzed to see if there were fewer antidepressants being prescribed, was there a commensurate replacement with psychotherapies? And there was not.
Oh my, yeah.
So you really, it paints a very, very clear picture because of the strength of that study and because of the numbers. They were in the millions of patients that this data comes out of. So that was really kind of the first step that really paints a clear picture. And then I think we can just converse and theorize about a number of other coincidental things that were going on, secular trends that were going on in the world, that I think this black box warning, in addition to, attitudes about medications in general, across physical and mental health conditions, the rates of adherence and acceptance of treatment. That's a well-studied phenomenon, that even when it comes to treating migraines and asthma, for example, the rates of, after the first month prescription is filled, to go on to stay on medication, there's a large drop-off. And again, so psychiatric conditions are not the only ones. So kind of just this, I would call it a very basic human feeling about the need for being on meds or treatment in general. And then there's the maybe some opinions and feelings about pharma, some for good reason, but possibly kind of bleeding throughout, attitudes towards big pharma. And I would even say for psychiatry in particular, those attitudes are different and more negative than for, say, other illnesses, where at AFSP we're collegial with other organizations like the cystic fibrosis and rheumatoid arthritis and multiple sclerosis, et cetera, et cetera. And in those populations, it's so fascinating to me that the view of pharma there is to come alongside patients and families and develop treatments that are needed to save lives. And somehow in psychiatry, we don't benefit from that same, I think, rational viewpoint. Now, again, I think this is just cultural beliefs are very complex. And again, there are some instances and some very famous and infamous instances where there was extreme harm done. But again, I would say, we have to look at the balance of things. And then the last thing I would say about just secular trends is that there is this notion that natural substances, including some illicit drugs and now legalized drugs, are sort of all good. Natural equals all good and synthetic equals all bad. And that belief, again, so I think it's many different things, but I think it has created a sense of fear amongst any number of not just clinicians, but the parent community and then just the general population. And people look on the internet when their doctors are talking about the, treatments that they're recommending. And so it has become, I think, even more difficult to really appropriately and aggressively treat depression like I feel like we might have been on the right track towards doing back in the sort of 90s.
Yeah. Yeah, to your point there about natural, I like to say sometimes that people seem to like their treatments, their medicines with stems and leaves attached, as if natural is better, when the fact is these are all chemicals. Even if you're getting something natural, there's some chemical in there.
That's right.
And ideally, the medicines that are FDA approved have faced much higher scrutiny as far as safety and all of those things. I remember very well, Christine, as you know, I've been doing clinical trials getting drugs approved, and I remember doing trials in children and adolescents for the atypical antipsychotics in particular back in the 2000s. And there was, if you remember, a huge scrutiny, as you've said, especially on giving medications such as atypical antipsychotics to kids. And there were hearings in Congress, if you remember, about this. So you're right. We have to sort of remember the political climate at the time and the media climate at the time.
Well, and not to get political in this moment, but there are indications that we could be facing some similar types of scrutiny, that we need a balanced look. We absolutely need to take a look at adverse events, and obviously we'll get to it for the clinician and patients and families, looking at the balance of, risks and benefits of treatment, risks and benefits of alternatives, and the risks and benefits of not moving on anything. And all of that needs to be in the mix.
Yeah, that's so well said. I think sometimes when we're thinking of, risk benefit, we sometimes think just about side effects, but I like to say, well, what's the risk of inadequately treating the illness?
Yes.
And as we know, depression, as you've well said, is associated with suicidality as the worst outcome. Help me understand, you mentioned this was originally from FDA's database of antidepressants. Wasn't it mostly SSRIs, maybe SSRIs and SNRIs? That's my understanding.
Well, the data set that I looked at most recently, it may have started with just the SSRIs, but it did move into a state of including 9 antidepressants in the total data set that was being looked at. Now, in some of the pediatric studies that occurred after that time, then some of them took a look specifically at fluoxetine, and then there were several others that were added into some of the studies. So different data sets did include different ones.
And that's a point I want to come back to a little later when we talk about what might have been going on here and some of the factors that did explain a little bit of that increased risk. But let's also talk about the fact that you mentioned the rates of diagnosis and treatment have gone down. Sadly, as we all know, first of all, you mentioned the background of things. We know there's been a significant increase in suicide, particularly amongst even children, but especially adolescents and young adults over the past several years. And, people theorize social media and other factors contributing to that. But if we go all the way back, has there been an increase in suicides related to the warning that scared some HCPs away?
I think there is correlational data that we could theorize about. I'm very cautious about linking that up in terms of causality. Number one, because of the complexity of suicide. And when you look at rates and population rates, we could look at any number of things, including the economy. That was the trends that were going on at the time. We could look at, later, certainly the advent of social media. We could look at any number of things in entertainment and things that the population is sort of being influenced by.
Yeah. How about substance use? The increased rates of substance use could be part of it. Yeah.
Huge. I mean, as the opioid crisis, sort of began and then carried out and throughout different communities more so than others in the United States, we saw, obviously not only a rise in accidental opioid and other drug overdose deaths that has just been obviously tragic and unprecedented, but the relationship between substance use and suicide, I think, has been a little bit short-shrifted historically. And I even point back to the odd sort of separation if you look at our terminology even. And, SAMHSA, one of our federal agencies, that's the Substance Abuse and Mental Health Administration, there's a history of our field kind of separating out substance use from mental health and from psychiatric conditions. And I think that mindset we're still kind of having to undo some kind of like basic assumptions. And so with suicide risk in particular, there are at least 3 different things that I think about that something like the opioid crisis has an effect on suicide rates. And so that is that obviously addiction itself is a risk factor, a very significant risk factor for suicide, as is just the prevalence of lethal means, which opioids and particularly fentanyl can represent just the accessibility of a lethal means. And then you have the accessibility of substances in general, which you don't have to have addiction to have substances be playing a really significant role in suicide risk for an individual. And then the last one I would point out is that there's a percentage of suicides that are never called suicides. And that's for any number of appropriate and inappropriate reasons. And by appropriate, I would say just that medical examiners, in the face of really looking appropriately, searching all of the medical and the death investigation data that's there in front of them, they may not be able to call it an intentional suicide death. But there are also inappropriate ones where we know there's a study that shows that the counties that have coroners who are not medically trained individuals who are leading the death investigation and the determination of cause of death, that those counties compared to the counties that have medical examiners, they are more likely to be socially influenced by stigma to not call an actual suicide death a suicide. So anyway, so there's going to be a intersectionality of overdose deaths, some of which are actually suicides that are called accidental, and then there are the ones that are undetermined for sure, and those, of course, a percentage of those could also be suicides. So it's a very interrelated kind of areas. And I think from the clinical perspective, what the basic thing to understand is that rather than having a siloed approach in terms of like the buckets that you're putting clinical features into, we actually need to create some sort of collaboration between the parts of our brains where we're thinking about substance use, we're thinking about mood disorder, we're thinking about family history of any number of things, we're thinking about previous trauma. And when I think about suicide, and one of the biggest changes in clinical practice that is best practice now is to look at suicide risk as its own clinical target, its own clinical entity. That means you have to make space in your clinician's brain and, space in the medical record to be constantly evolving that suicide risk assessment based on what we know from science can elevate risk, the protective factors, and then, of course, people's lives are evolving continuously and clinically changing, as well as the psychosocial factors changing. And of course, with suicide, we know that it has a lot to do with a person's clinical state, but it also has a lot to do with transitions in life, losses, rejection, and various. I actually believe that for each individual who is at risk of suicide, there's I wouldn't necessarily call it unique, but a way that we can approach in a precision medicine-like way to help them and ourselves as their provider understand for them what are the unique drivers and the unique protective factors.
Yeah. And you mentioned trauma, which we know is a significant risk for your entire life, for mental illness and suicide, sadly. But you made me think of something else there as you were talking. It sounds like the actual rates of suicide are underreported, and that complicates this as well, to not really understand the full breadth of the problem.
It does. You're absolutely right. I mean, when we think about any other leading cause of death, part of a robust public health approach, and one where you can measure the effects of different interventions and treatments and public health strategies, is you have to be able to have a really solid and clear sense of surveillance of the problem itself. And with suicide, we've always had the challenge that it lags behind by a couple of years, and the CDC had been getting better and better at that. So we got it down to almost a year only of lag behind. Now, a county by county level, suicides are counted up in much more real time, but we wait for the national rates for that length of time, between 1 and 2 years. But yes, I think as stigma has gone down, we do have reason to believe that the accuracy of calling suicides what they are, it has improved, but to that limitation, which will always be there, that in some instances, there's just not enough data for the medical examiner to be able to call it a suicide.
Sure. Now, we've talked about the effects of this warning on the perceptions and behaviors of healthcare professionals, but what about for families?
I think there's a lot of misinformation out there. What we're talking about today, even just in terms of, that issue that I mentioned at the top of the hour, that the original data set was not able to account for previous suicide risk and whether there were improvements or worsening. It could only measure adverse events. So that is a very rough tool to begin with. And that I think that is not known by most clinicians, let alone families. I think if families could understand that untreated depression, PTSD, substance use problems are going to be far and away a greater risk to your child than the appropriate judicious use of treatments, including medications, that would be my one, wish for a takeaway from this conversation is that that clinicians could hold on to maybe a couple of ways that they might add into their informed consent process, because it is hard to help parents and patients understand all of this, because it's complex stuff for us to understand.
Sure. But specifically, how has it affected family and even the patient's perception of antidepressant safety and efficacy to some degree?
I think it's had a very chilling effect where the assumptions are around harm and only looking at harm. And again, that's important to look at very carefully and in the whole balance of the data we have to look at. But it does not account for the potential benefits, nor the potential for harm if you use a different modality or do nothing at all. And I think the thing that worries me the most is honestly the fact that we haven't made much headway as a society in our overall, the fact that mental health conditions generally show up in young people's lives as they, their age of onset. It's 50% by age 14 and 75% of mental health conditions by age 24. And yet, across all Americans with psychiatric conditions, less than half are receiving treatment. So we are still missing that first step of identifying. And I understand that for parents and even sometimes pediatricians, it can be tricky business differentiating kind of normal developmental stages and all of the transitions that occur in normal childhood development, which there's a lot of change going on. But I think my personal opinion is that we had started to make some very good headway in the understanding of major depression as a serious and life-threatening medical illness, that it was being treated as such. And now we've slid backwards because of this sort of fear and conflation.
Yeah, you're right. It sounds like that families and patients have become afraid of antidepressants. I mean, as you said, it's responsible to be concerned about risks, and it's important for us as healthcare providers to do a full informed consent of all the possible side effects and risks. But unfortunately, as you've said, fear both by clinicians and by patients and families has decreased the use of these medications appropriately.
Yes.
You've talked about people at youth. Are there certain populations or subgroups of young patients who may be more vulnerable to these warnings and to the consequences?
Well, I think that we know that certain mental health conditions really evolve significantly over the course of the young childhood years into pre-adolescence and then through the teen years. So I'm thinking about the child who initially it might look like impulsivity, hyperactivity, some mood lability, maybe a little bit of oppositional, a lot of reactivity. Those kids, and depending on what their family histories look like, and depending on the competence, frankly, of the clinician to look at that whole picture, they may have an evolution of diagnoses. And I would say even with the best clinicians involved, sometimes there is, right? So that they may look like they have ODD or ADHD, and then maybe a mood element develops on top of that. anxiety can be a significant component and oftentimes is one of the most early and heralding signs of not only an anxiety disorder, but of the potential for other disorders to emerge, like depression, like bipolar disorder, like
Even-
ADHD.
Yeah, and even schizophrenia,
Yes.
at first looks like this, the prodrome, if you will.
Exactly. So, I do think that the undetected, either bipolar disorder, certainly that would be the most clear-cut at-risk group for an unopposed antidepressant to have some less than typical effects, right? It oftentimes can look like some mood improvement, but it can also look like there's agitation, insomnia, sometimes a mixed state type of clinical presentation can occur. And I think those are all that can be actually used sort of diagnostically, not definitively, but can help a clinician, right?
Right. So maybe some subgroups would include those with a strong family history, maybe of mental disorders,
Yes.
those with trauma, maybe those who don't have great social supports or learn good coping skills, substance abuse. I think we've identified a number of risk factors here. One of our colleagues, one of our NEI faculty colleagues, Manpreet Singh, who's a real expert on child-adolescent mood disorders, taught me that bipolar disorder usually presents not with an obvious mania, but more with mixed states, as you mentioned. And those mixed states, that's absolutely been shown to be a higher risk for suicide. Yeah.
That's right. So I think, being very meticulous with children and adolescents, with the history taking and really asking in different ways to elicit what are the experiences that child is having internally, because these are not, they don't necessarily have the language for it to just say, tell me how you're feeling. And then, of course, the family history as well can be incredibly helpful, as you say. I do think one thing that's not very well known is that the emergence of ADHD as a risk factor for, as one of the mental health conditions that is a risk factor for suicide, that was only made clear in the last maybe 5 to 7 years. We didn't really have good data on that before.
Absolutely.
And so, but I think rather than, here's the real challenge. When I am thinking of suicide risk, which is what I'm always thinking about, I'm thinking about coming in closer to that person, really trying to determine what is the best course of treatment and support, educating the family, of course, but it does not mean backing away from medications. It means being extra careful about the diagnosis and extra careful about the choice of medication, and of course, then the monitoring, especially early on.
Yeah. When you're talking about ADHD, the classic study was in 2019 by Sun and colleagues, and my friend Steve Ferrone is an author on this, and this showed 1.5 times increased risk of premature mortality was the actual thing if you just have ADHD. With each additional comorbidity, your risk of premature mortality goes up logarithmically, not linearly. So, of course, if we throw depression, anxiety, substance abuse on top of ADHD, and of course, the driver of this premature mortality includes natural causes such as cardiovascular disease and so on, but also unnatural, meaning suicide and accidents. And there's been some recent studies that have actually shown appropriate treatment for ADHD decreases the risk of suicide. So I really appreciate you bringing up ADHD, which a lot of people think, oh, you're just a little spacey and forgetful, but it's also a serious medical illness, biologic illness with consequences. I wanted to talk also a little bit about some possible explanations for this risk. And I've heard some people theorize that, well, when you give depressed people antidepressants and they start getting energized and then they can act on suicidal thoughts. And certainly that may be part of it. But I think you brought up a really important point. And that is the DSM does us no favors, Christine. The DSM describes a major depressive episode, which is not a diagnosis. It's described the same way, whether it's unipolar MDD, which is a diagnosis, or bipolar depression. And it's really the syndrome. A syndrome is a collection of symptoms. So you have a major depressive episode. You know, if somebody had fever, chest pain, and cough, we would know to look for the cause, the underlying diagnosis. And I think your point you made about when you recognize a depressive episode, we should really be careful to screen for what is underlying that, what else could be causing that. And I think the really important one, and perhaps one of the biggest messages to our colleagues here, is you must screen every depressed patient for bipolar disorder. And particularly, it's interesting that what I'm about to quote, which is data from Barbara Geller and colleagues at WashU in St. Louis, dovetails perfectly with the warning for suicidality with antidepressants, and that is, if your first episode of depression is before the age of 24, which means, before the age of 25, which means 24 and under, that triples the odds that you're bipolar, Christine. And interestingly, the warning in the label actually says 24 and under. It's the same population, but from different data sets, which really makes me think a possible explanation would be, as you said, someone who actually has bipolar disorder, which is hard to diagnose, and they're given an unopposed, as you said, antidepressant, traditional antidepressant, which I call non-mood stabilizing antidepressants. And of course, either the antidepressant doesn't work and bipolar progresses, and we know it's associated with suicide, or it actually makes them a little worse, and then they become suicidal.
Absolutely. I think that's one of the most clear-cut steps for clinicians to do and to walk away with. I think there are a number of other potential reasons that in the early stages of antidepressant treatment, you can see some less typical experiences that people can have. And, you know, we've seen, for example, a subset of patients be exquisitely sensitive to medications in a way that is far and away different and more severe than our typical patients' response. So there's that subset of patients. There are those that probably for any number of, whether it's bipolar or other brain-related reasons, that they do develop some transient side effects that can look like agitation, insomnia, anxiety. You know, you think about the changes that are going on in the brain during the several weeks after starting a medication, and they are quite significant. And it's an evolution. It's a dynamically changing thing going on with, you know, pre and post synaptic and all of that upregulation, downregulation. And so during that period, some people are very sensitive and feel differences. So I think the overall impact that can have on an individual, I was always really careful to just explain that for several weeks, there will be physiological changes that are going on. You may or may not feel them, but, you know, if you do, I want to hear about them. And, you know, so I think there are just some unique aspects about the brain and the way people experience changes in the brain that in the end, it may land in a very good place, but it may require some patience and some extra guardrails, if you will. You know, I do worry that when clinicians aren't available to have some real-time handling of, you know, feedback or providing some guidance in those first couple of weeks, it can be like really probably 2 to 3 to even 4 weeks. And then less so, but with changing the dose as well. So I think there's that. I do think there is this experience that we see where the rate of change of certain types of symptoms is different, meaning the cognitive symptoms of depression may be some of the last to improve, so that people are, maybe feeling more energized, but their mood and their cognitions and their cognitive effects of the depression may not be improving at the same rate. And that's a very kind of confusing and frustrating experience. So I do think that there's a number of things, and I think there may be that kind of classic one that people talk about where energy's increased, but suicidal thoughts are still there. That absolutely could be, but I think it's any number of these kinds of experiences.
Yeah, I don't think it's that simple or any one thing. And you're certainly right that we know that when you start an SSRI or an SNRI in particular, there can be some initial agitation and activation that gets better, as you've said, as the neurotransmitters kind of balance out and you get up and down regulation of receptors and all this kind of thing. So I think a very responsible point here we're making is we need to be monitoring. First of all, we need to have good informed consent, and we need to let people know what to do if you do notice something like this. And we need to be monitoring especially closely in those first few weeks. And also, I think we need to be very vigilant about modifying our diagnosis should things not go well, as we've said.
Yeah.
You know, something that concerns me too, Christine, is this sort of broad brush approach the FDA has applied. And by that, I mean, I talked about the traditional non-mood stabilizing antidepressants, but now the atypical antipsychotics that have been FDA approved for bipolar depression have also gotten this warning. And yet the data suggests that atypical antipsychotics decrease suicidality, especially in bipolar patients. So it's almost unfair that they've also gotten tarred and feathered, if you will, by this broad brush.
Yeah, it seems that FDA uses a sort of categorical approach. And so if they had applied it originally to antidepressants and now with different mechanisms of action that are being looked at, but where there are mood elements and particularly being used in depression, even adjunctively, that they just apply this sort of broad sweeping, as you say, and really, I'm sure they're thinking it's a cautious approach, but the problem is it can actually be just an inappropriate and unhelpful approach.
Well, I think many of our colleagues have had the experience I've had where someone reads this warning, particularly with an atypical antipsychotic, and on top of all the other concerns about atypical antipsychotics, they say, I'm afraid of this medicine, I don't want to take it. And I like to make that distinction I made earlier between non-mood stabilizing antidepressants versus the 5 atypicals that are approved for bipolar depression, in my mind, are mood stabilizing antidepressants, if you will.
Absolutely. I see it the same way.
Great. Well, let's move on now to what else is going on and what we're doing about this. So are there any alternative approaches or interventions that people are starting to push back on the FDA or trying to deal with this?
You know, it is something that has been on my mind. And so I'll just give you a couple of thoughts about that. A lot of time has transpired. It's been over 20 years since that original black box warning. We have more data. So the challenge and the caveat is that we don't have, and we probably will not have, a randomized controlled trial with suicide as the intended outcome of, primary outcome. And so not having an RCT for any medications related to suicide-related outcomes, we have to then look at the existing data and methodologies that we have available. So, and there's actually quite a lot. I mean, so some of the data that I think we would need to be looking at is obviously would be pediatric data. And that makes it even more challenging. There's a lot of adult data that would speak to the actual trends in suicidal ideation and behavior that we now can paint a picture of, that we didn't have these studies back in 2004. So, for example, we now have Greg Simon's study of 74,000 patients in that mental health research network that tracked suicidal ideation before treatment was initiated, and then as an antidepressant and or psychotherapy was initiated. So you see the 3 months leading up, you see the start of treatment, and then you see the 6 months following the start of treatment. And what you see is that the incidence of suicide attempts is about 2 to 3-fold in the 1 month before treatment is initiated, whether that treatment is a medication or psychotherapy. So these are the aspects that were not considered by the FDA at all. Sort of in a way, the course of suicidal ideation and behavior, not that it's monolithic, but across a patient population. We also have a study that Sid Zissuk and others, and I was a part of this study. We called it COMED, and it was looking at, again, it was a secondary analysis looking back retrospectively, 665 patients on 3 different antidepressants. And again, the beauty of this study is that we had their data about suicidal ideation or behavior before they were initiated on the antidepressant or before a switch occurred. And the outcome of that study really showed that the course of suicidality was that those who had some baseline suicidal ideation or previous suicidal behavior, recent suicidal behavior, when their treatment was started, the vast majority, I think it's 86% and even higher in some groups, out to 28 weeks, their suicidal ideation had resolved. So that is the more typical course. There were there was a small percentage where there was some newly emergent suicidal ideation. And so that is overall helpful and positive. The tricky thing, again, being that these illnesses themselves are a very potent, powerful risk factor for feeling suicidal as well as for suicide itself. And so when these illnesses are not fully addressed and in a full state of remission, they are still actively potentially contributing to suicidal thoughts. And so that's a challenge there that is continually, going to be a challenge to tease out. There's a number of other data that we could look at that generally points to the helpful qualities about antidepressants as far as reducing suicide risk. The real thing, I think, when it comes to reapproaching the FDA about any type of new analysis to take a look at this black box warning, is that you need to have not only the data, and in the absence of RCT type of methodology, I am concerned about that as a gap. But even more than that, you need to have the patient advocate voice and the family voice very strongly at the table, because that was in the recent schizophrenia and clozapine vision.
That's
that
right.
was an extremely strong aspect to that, those procedures. We're hearing from the families and individuals themselves.
Right. You're talking about the revision on monitoring of white count of blood work. Yes. Yeah.
Right.
Yeah.
And even when you look at the original FDA hearings about the black box warning for antidepressants, there was such a strong outcry, and again, a very tragic loss of young people. And the people who had been helped and whose suicide had been prevented, those are the stories that are more difficult to capture because they're not the activists waving the flag as much. Although I'm happy to say that in the world of suicide prevention and AFSP, we do have actually thousands of people and families who some have experienced loss, many are loss survivors, and many are families with lived experience, meaning their loved one or they themselves have lived through suicidal crises and experiences. And that is a whole new way of understanding suicide risk and prevention as well. And I'll just say one more thing that I think is just incredibly important. It's the inclusion of people who have suicidal experiences in clinical trials. That, for many, many decades, that was not allowed. That level of
Oh,
risk was not tolerated.
oh, I know it well from years of doing such studies.
Yes. And now I'm happy to say that is changing, maybe a little bit slowly, but in many instances, there is a full realization that suicidal ideation and behavior are part of the course of many people's lives, part of the course of illness in many cases. And if we exclude it, just like we used to exclude women and other, major populations, we don't allow the study of these medications and treatments in really relevant human beings. So that's just something that's still, I think, a work in progress, including suicidal people.
You alluded to the lack of RCTs, and of course, the traditional belief has been somebody who's actively suicidal, it's almost unethical to enroll them in a placebo-controlled trial where they might get placebo unless you have very significant monitoring in place. And some recent studies looking at some rapid-acting antidepressants in acutely suicidal patients, they've required them to be hospitalized during at least the initial part of the treatment, which I think makes sense.
Right.
So there are ways perhaps to do something like that. But what I love is how you're talking about the bigger picture, and we really need to look at the full picture, the bigger picture here. Now, you've alluded to your role with AFSP, it's the American Foundation for Suicide Prevention, of which you're chief medical officer. How has AFSP addressed this complex interplay between medication safety and suicide prevention, especially in younger people?
We at AFSP we conduct a Harris poll of the general public. And so we've been kind of tracking the culture, attitudes, and beliefs around suicide, mental health, treatment, any number of these important topics over, I'd say, the last 10 or 12 years. And what we're seeing is an opening up of the acceptance of mental health as a true aspect of human health, a pivotal one. In fact, we could even say there's kind of an outcry for the accessibility of treatment and the support, peer support, family support. So I say all that to say that when it comes to finding the treatment that works for the individual, that is the message. The message is it's a public health approach that we've been taking to try to kind of raise all boats up so that the understanding that mental health conditions are common, are prevalent, that they don't have to be disabling in the way that we might think of that kind of, classically very psychotic individual or chronically severe mental illness, but that people, I got my start in suicide prevention because of the suicide loss of physician and nurse colleagues. So folks can be extremely high functioning and have mental health conditions that are not being addressed or only inadequately being addressed, and where suicide risk then is left to sort of fulminate. So it's all to say that we haven't really, taken it on too specifically. AFSP is not funded by corporate America. We are largely funded by the average $24 donation that our walkers in our Out of the Darkness walks have been raising the funds to really create this movement and awareness. We're the leading private funder of suicide research based on those Out of the Darkness walks. So we take that responsibility very seriously about the public's interest in suicide prevention. And I think we're getting more and more. This conversation has been such a treat for me because I get to express the nitty-gritty of my opinions in a way that are at AFSP, we just have such beautiful social media presence and messaging that is really trying to bring everybody along and essentially start conversations so people aren't remaining silent about their suffering, and then help those in their lives lead them to appropriate help, which then that will get to the point of the primary care providers and mental health practitioners, psychiatrists, psychologists, and all actually need education and help in terms of, in a way, normalizing conversations about suicidal thoughts, understanding that suicidal thoughts are incredibly common in the general population. suicidal behavior is a different matter. And so really, helping develop some nuance around those basics first before we go full bore. But our research program is all over all of it. I mean, innovative, new molecules, biological, we're, looking for biomarkers for suicide risk. It includes all of that.
Yeah. Well, I think it would be fair at this point to put in a plug for AFSP and maybe encourage our audience to financially support AFSP and help with your mission, because you certainly do incredibly good work. I think I'd like to also mention one other thing before we wrap up here, and that is one of the factors we haven't really talked about is the epidemic of loneliness in America. And our good friend Roger McIntyre has done a lot of work and published about this, and it's very clear that loneliness is a significant risk factor for depression and suicide. Yeah. And I hope that we're thinking and talking about that and ways to maybe address the loneliness epidemic as well.
Absolutely. I mean, if you even look back before the Surgeon General identified, the epidemic of loneliness, some of the most effective strategies in suicide prevention, particularly in older adults, were in addressing just that. So it was very much a community approach that relied on training any number of community members in the clubhouses and Meals on Wheels, in social supports for older adults to be able to have conversations about how they're doing, and checking in on them. I mean, so it's fascinating that there was a trend down in the suicide rates among the older adults of America, so much so that middle-aged adults' suicide rates overtook and surpassed older adults some years ago, in about 2015. Now we're seeing a reversal of that trend with older adults' suicide rates having gone up again. But for a period of time, we were actually pointing to the social support piece as a significant contributor to effective suicide prevention.
Yeah, that's fascinating. I think one of the messages here we can leave our audience with is the importance, as we said, of really individualizing your assessment, evaluation, your diagnosis, and your treatment. Unfortunately, I feel like there's some clinicians that do a one-size-fits-all approach. I always, for instance, start with an SSRI or something. And maybe we need to be a little more granular, a little more individualized in our approach to this, because it is complex. That's certainly one of the messages I think we're getting across here. I'd like to wrap up here with, I don't see the FDA getting rid of this boxed warning, but are there ways to modify it or other kinds of things that can be done to, soften it, if you will, or maybe counteract some of the fear and the things we talked about, the decreasing in assessing and treating and the increase in suicides in youth? Are there specific things that can be done with that warning?
I'm not sure, honestly, short of retracting it altogether, because again, the 2007 modification was not effective at mitigating the negative unintended consequences. Now, I will say, if it's the FDA or some other, body with a large sweeping ability for a campaign that would touch many, many people, including clinicians, but including the general public as well, I would say that there could be an educational campaign that could have some positive effect, that could maybe boil down our conversation into, let's say, the top 5 relevant things about the data set to begin with, in a way, the flawed nature of producing a black box warning based on only the evaluation of adverse events and not the evaluation of the bigger picture of what produces suicide risk and the improvements that can occur. That sort of fluctuation, suicide risk, is very dynamic over time. So it's a really good question, and it's actually one that I raised recently with our colleagues Steve Stahl and Jonathan Meyer, because I saw what was happening around clozapine, and it made me wonder, could there be a moment where we approach the FDA? And there could in the future, but we would need a very strong voice from patients and families to try to balance out that sense of suicide loss being related to one thing primarily, which, that step one in suicide prevention education is that it's not a one cause effect phenomenon.
Right. And also, unfortunately, there was this sort of myth, I think, at one point that if you bring up suicidality, you ask about it, it's somehow going to plant the seed or make it more likely to happen, when actually isn't the opposite true?
Absolutely. And that myth has been dispelled by several studies. People still worry. I think they're uncomfortable, they're anxious, but I think there also might be a little bit of conflation with the real phenomenon of suicide contagion, which occurs by a completely different set of circumstances with sensationalized graphic portrayals and discussions. Asking someone how they're doing in a caring, compassionate, competent manner, including if they're having thoughts of suicide, is not harmful. It helps them to be able to open up and potentially sort of come out of that state of paralysis and start getting the help that they need.
Yeah. Something that just occurred to me, in some ways this is similar. I just recorded a podcast with my beloved professor and mentor from University of Virginia, Anita Clayton, who's the chair there now. And she trained me, 30-something years ago, that there are certain taboo subjects that we must ask about, and that includes sex, which is, of course, her main area of focus, religion, money, and I would add now suicidality. We should be fearless in providing a permission structure or a safe place to talk about these things. Well, Christine, as always, I have greatly enjoyed this conversation, and I'm positive that our audience has gotten a lot out of this. Perhaps I feel like we could keep on talking, so I'm going to ask you selfishly if we can talk again, perhaps do another podcast, and certainly have you speak again at our NEI meetings. But is there any final thought before we wrap up you'd like to leave our audience with?
I think the main thing is for clinicians and anyone, all the hats that you wear in life, is when you think about the topic of suicide, understand that science is a game changer, and it is happening in leaps and bounds right now. There is a lot of reason to hope. As stigma goes down, we can approach the topic. People with their own lived experience, including myself, are able to speak about it and talk about that hope, healing, and recovery. And those are the messages that I think can be so impactful. And you as a clinician, having some, confidence to be able to speak about that. I worked on physician suicide prevention for, more than a decade, and I had always justified it in my mind that we won't be able to do right by our patients until we really have a level of confidence and get rid of stigma in our own lives and with each other, the support that we can have with each other. So I would just encourage everyone in that regard.
Yeah, and I think we've given a lot of practical recommendations. And I think one thing when you say science, I've certainly worked on a number of novel mechanisms for antidepressants. And, this warning came from primarily monoamine-based treatments, reuptake inhibiting drugs. But we know that some of the newer mechanisms, medications such as glutamate-type drugs, ketamine, S-ketamine, and some of the others, and perhaps even psychedelics, they may not be associated with the same risk. They may actually in some ways decrease suicidality. So I'm very excited, and I'm glad we're leaving our audience with a hopeful message for the future that all of these things can help decrease the scourge of suicide. So Christine, I want to thank you very much, and I want to thank our audience for listening. And for more podcasts, for more of our educational offerings, please visit our website, which is neiglobal.com. That's neiglobal.com. Thanks again. Look forward to seeing you again, Christine.
Thanks so much, Andy. Take care.
You too.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.